class, welcome to Chapter 14, Medical Overview. After students complete this chapter and the related coursework, they will understand the need for proper assessment techniques when called to patients with a chief complaint of a medical nature. Introduction. Patients who need EMS assistance generally have experienced a medical emergency or a trauma emergency, or both. Trauma emergencies involve injuries resulting from physical forces applied to the body. Medical emergencies involve illnesses or conditions caused by a disease. It is important to remember that patients may have a combination of medical and trauma conditions. Types of medical emergencies. Respiratory emergencies occur when patients have trouble breathing or when the amount of oxygen supplied to the tissues is inadequate. Diseases that can lead to respiratory emergencies include asthma, emphysema, and chronic bronchitis. Cardiovascular emergencies are caused by conditions affecting the circulatory system. Common examples include heart attacks and congestive heart failure. Neurologic emergencies involve the brain, may be caused by seizure, stroke, or fainting, syncope. Gastrointestinal conditions include appendicitis, diverticulitis, pancreatitis, and many others. A urologic emergency can involve kidney stones. The most common endocrine emergencies are caused by complications of diabetes mellitus. Hematologic blood emergencies may be the result of sickle cell disease or various types of blood clotting disorders such as hemophilia. Immunologic emergencies involve the body's response to foreign substances. Allergic reactions are a type of immunologic medical emergency that can range from fairly minor to life-threatening. Toxicologic emergencies involving poisoning and substance abuse result in other types of medical emergencies. Gynecologic conditions are a special category of medical emergencies that involve the female reproductive organs. Some medical emergencies are caused by psychological or behavioral problems and may be especially difficult to deal with because patients often do not present with typical signs and symptoms. This table shows types of common medical emergencies. Patient assessment. Assessment of the medical patient is similar to the assessment of the trauma patient, but with different focus. Medical patient assessment is focused on the nature of illness, the NOI, symptoms, and chief complaint. Establish an accurate medical history. Use dispatch information to guide your initial response, but do not get locked into a preconceived idea of the patient's condition. Injuries may distract from the underlying condition. Tunnel vision occurs when you become focused on one aspect of the patient's condition and exclude all others, which may cause you to miss an important injury or illness. Assessment may be difficult with uncooperative or hostile patients. Maintain a professional, calm, non-judgmental demeanor at all times. Refrain from labeling patients and displaying personal bias. A frequent caller may have a different complaint this time. The major components of a patient assessment are scene size-up, primary assessment, history taking, secondary assessment, and reassessment. Scene size-up. Scene safety. Ensure the scene is safe for you and your crew and your patient. Use standard precautions. Determine the number of patients and whether you need additional help. Determine the NOI. Signs and symptoms. The index of suspicion is your awareness and concern for potentially serious underlying and unseen injuries or illnesses. Initiate spinal immobilization if indicated. Primary assessment. Develop a general impression. Perform a rapid examination of the patient to identify life threats. Visual clues include apparent unconsciousness, obvious severe bleeding, extreme difficulty breathing. Quickly determine the patient's level of consciousness using the AVPU scale. Airway and breathing. In conscious patients, ensure the airway is open and they are breathing adequately. Check the respiratory rate, depth, and quality. Consider applying oxygen if breathing has been affected. For unconscious patients, make sure to open the airway using the proper technique and take several seconds to evaluate their breathing. Apply oxygen to patients in shock with difficulty breathing when low oxygen saturations are measured, a SpO2 of less than 94%. Unconscious patients may need airway adjuncts and ventilatory assistance with a bag valve mask, or BVM. Circulation. Assess the circulation in a conscious patient by checking the radial pulse and observing the patient's skin color, temperature, and condition. For unconscious patients, assess the circulation at the carotid pulse. Transport decision. The following patients should be considered in serious condition and in need of rapid transport. Patients who are unconscious or have an altered mental status, patients with airway or breathing problems, patients with obvious circulation problems such as severe bleeding or signs of shock. If the patient does not meet the criteria for rapid transport, continue your assessment on scene and prepare for transport when you have completed the assessment and treatment. History taking. Determine what the problem is or what may be causing the problem. Gather a thorough history from the patient, any family, friends, or bystanders. Investigate the NOI by inquiring about the chief complaint. Ask about the history of the present illness and ask follow-up questions. For an unconscious patient, survey the scene for medication containers or medical devices. As you continue to gather information, remember to obtain a sample history and to ask questions about the patient's chief complaint using the OPQRST mnemonic. Record any allergies, medical conditions, and medications, such as prescriptions, over-the-counter medications, and herbal medications. Some patients take numerous medications. Take the medications with you to the hospital and list them in your report. Determine if the patient is compliant with his or her drug regimen. The mnemonic TACOs can be helpful in identifying conditions that may be complicating a patient's chief complaint or affecting medications. T stands for tobacco, A for alcohol, C caffeine, O over-the-counter medications or herbal supplements, S sexual and street drugs. Scan the scene for clues about the patient's medical history that might help you understand the current medical emergency. Secondary assessment. The secondary assessment may occur on scene or en route to the ED. In some cases, you may not have time to conduct a secondary assessment. Physical examinations. All conscious patients should undergo a limited or detailed physical examination based on their chief complaint. For unconscious patients, you should always perform a secondary assessment of the entire body or head-to-toe examination to obtain clues to assess the problem. A full body assessment should help you obtain clues and should be performed quickly so it does not delay transport. If the patient's condition warrants the secondary assessment, examine the head, scalp, and face. For possible trauma, check the ears, eyes, nose, and mouth. Examine the neck closely. Look for evidence of accessory muscle use. Check for jugular vein distension, a tracheostomy, or a stoma. Assess the chest and abdomen. Check for breath sounds. Palpate the chest and abdomen. Check for medication patches, rigidity or distension, and scars. Check the pelvis and genital area. Palpate the legs and arms. Look for swelling or abnormalities. Check for distal motion, sensation, and circulation. Examine the patient's back. Treatment will depend on the condition or conditions found and your local protocols. Vital signs. Assess the pulse for rate, quality, and regularity at the most appropriate site. Identify the rate, quality, and regularity of the respirations and any difficulties that may be apparent. Obtain an initial blood pressure, measuring both systolic and diastolic pressures. Consider using the automatic blood pressure cuff for future assessment at regular intervals. Consider obtaining a blood glucose level and a pulse oximetry reading. Reassessment. Once the assessment and treatment have been completed, Reassessment should begin and continue throughout transport. Repeat the primary assessment and reassess the chief complaint. Consider the need for ALS backup. Repeat your physical examination to identify and treat changes in the patient's condition. Obtain vital signs every 5 minutes for unstable patients and every 15 minutes for stable patients. Review all treatments that have been performed. Document any changes that have developed as a result of the treatments, and if needed, adjust any treatments accordingly. Medical transport and destination. Most medical emergencies require a level of treatment beyond that available in the pre-hospital setting. Patients may require advanced testing available in the hospital. It may be beyond the scope of an EMT to administer medications to a patient. Any administration of medication by an EMT requires direct permission from the medical control. EMTs can use an automated external defibrillator, an AED, on a patient who is pulseless and apneic. Scene time. Scene time may be longer for medical patients than for trauma patients. Gather as much information as possible to transmit to the ED. Check the patient's living conditions. Critical patients always need rapid transport. They include patients with altered mental status, patients with airway or breathing difficulties, patients with signs of circulatory compromise, and patients who are very old or very young. Type of transport. If a life-threatening condition exists, the transportation should include lights and sirens. If the patient is not critical, considered non-emergency transport. Much safer method of transport and will often result in arrival only a few minutes later than an emergency transport. Modes of transport ultimately come in one of two categories, ground or air. Ground transport EMS units are generally staffed by EMTs and paramedics. Air transport EMS units are generally staffed by critical care transport professionals and paramedics. When you are considering ALS support for a patient, compare time for a ground ALS unit to respond and transport to the time required for an ALS helicopter to respond and transport, as well as the urgent resources needed by the patient. Designation selection. Generally, the closest hospital should be your destination. At times, however, the patient will benefit from going to another hospital that is capable of handling his or her particular condition. Infectious diseases. General assessment principles. Approach the patient with an infectious disease like any other medical patient. Perform scene size-up, take standard precautions, and complete the primary assessment. Gather patient history using OPQRST to elaborate on the patient's chief complaint. Typical chief complaints include fever, nausea, rash, pleurisy, chest pain, difficulty breathing, vomiting, and diarrhea. Obtain a sample history and a set of baseline vital signs. Pay particular attention to medications and the events leading up to today's problem. Ask whether the patient has recently traveled or has come in contact with someone who has traveled. General management principles. Focus on any life-threatening conditions identified in the primary assessment. Be empathetic. Place the patient in a position of comfort on the stretcher and keep them warm. Use standard precautions. Always follow your agency's exposure control plan in cleaning equipment. Properly discard any disposable supplies and wash linens. Epidemic and pandemic considerations. Epidemic, when new cases of a disease in a human population substantially exceed what is expected. Pandemic, a disease outbreak that occurs on a global scale. A flu pandemic occurs when a new influenza virus emerges that spreads easily from person to person, causing serious illness, and is found in multiple countries in a short time. Common and serious communicable diseases. Influenza. Influenza, or the flu, an animal respiratory disease that has mutated to infect humans. Those with chronic medical conditions, compromised immune systems, and the very young and the very old are most susceptible to complications of influenza. Transmitted by direct contact with nasal secretions, aerosolized droplets from coughing and sneezing by infected people. H1N1, initially defined as the swine flu, has been present for years in animals and was initially identified in 2009. It has caused many deaths and has caused awareness of routes of transmission. For diseases that can be passed by the respiratory route, always wear PPE, such as gloves, eye protection, and a HEPA respirator. Wash hands frequently. Place a surgical mask on patients with suspected or confirmed respiratory disease. Wear a HEPA respirator during aerosol-generating procedures, such as suctioning. Annual influenza immunization is important for EMS personnel to protect providers and patients. Herpes Simplex. This is a common virus strain carried by humans. Of individuals carrying the virus, 80% are asymptomatic. Symptomatic infections cause eruptions of tiny fluid-filled blisters called vesicles that appear on the lips or genitals. Can cause more serious illnesses like pneumonia and meningitis in the very young, very old, and the immunocompromised patients. The primary mode of infection is through close personal contact, so standard precautions are generally sufficient to prevent the spread to or from healthcare workers. HIV infection. EMTs face a risk of exposure to the virus that causes AIDS on a regular basis. No vaccine yet exists to prevent HIV/AIDS. AIDS can still be fatal. However, with treatment, patients can expect near normal lifespan. HIV infection is a potential hazard only when deposited on mucous membranes or directly into the bloodstream. It is not easily transmitted in the work setting. Your risk of infection is limited to exposure to an infected patient's blood or body fluids. Many patients with human immunodeficiency virus, HIV, show no signs. Always wear the proper type of gloves. Take great care in handling and properly disposing of needles and other sharp objects. Cover any open wounds that you have whenever you are on the job. If you think a patient's blood or secretions may have entered your system, seek medical advice as soon as possible and notify your infectious disease officer. Hepatitis. Inflammation and often infection of the liver can be caused by a number of different viruses and toxins. Early signs include loss of appetite, vomiting, fever, fatigue, sore throat, cough, and muscle and joint pain. Signs that appear several weeks later include jaundice, right upper quadrant abdominal pain. Toxin-induced hepatitis is not contagious. There is no sure way to tell which hepatitis patients are contagious. Hepatitis A can be transmitted only from a patient who has an acute infection, whereas hepatitis B and hepatitis C can be transmitted from long-term carriers who have no signs of illness. A carrier is a person or animal in whom an infectious organism has taken up permanent residence and may or may not cause an active disease. Hepatitis A is transmitted orally through oral or fecal contamination. Hepatitis B is far more contagious than HIV. Vaccination with hepatitis B vaccine is highly recommended for EMTs. This table shows the characteristics of different types of hepatitis. Meningitis. Inflammation of the meningeal coverings of the brain and spinal cord. Signs and symptoms include fever, headache, stiff neck, and altered mental status. Most forms of meningitis are not contagious. However, one form, meningococcal meningitis, is highly contagious. Take standard precautions. Gloves and a mask will go a long way to prevent the patient's secretions from getting into your nose and mouth. Vaccines are rarely used. Meningitis can be treated at the ED with antibiotics. After treating a patient with meningitis, contact your employer health representative. Tuberculosis. Many infected patients are well most of the time. A chronic myobacterial disease that usually strikes the lungs. If the disease involves the brain or kidneys, the patient is only slightly contagious. Disease that occurs shortly after infection is called primary tuberculosis. Reactive tuberculosis is common and can be much more difficult to treat, especially because an increasing number of tuberculosis strains have grown resistant to most antibiotics. Patients who pose the highest risk almost always have a cough. Consider respiratory tuberculosis to be the only contagious form because it is the only one that is spread by airborne transmission. Droplet nuclei, the remnants of the droplets produced by coughing after the excess water has evaporated. N95 or HEPA masks are required to stop droplet nuclei. Infectious agents can take hold in some patients much more easily because of reduced defenses. Such patients as elderly patients and people who are immunosuppressed from chronic illness, cancer treatment, or organ transplants. Absolute protection from infection with the tuberculous bacillus does not exist. According to the Centers of Disease Control and Prevention, 1/3 of the world's population is infected with tuberculosis. The vaccine for tuberculosis, called BCG, is only rarely used in the United States. The mechanism of transmission is not very effective. Have tuberculin skin tests regularly. If the infection is found before you become ill, preventive therapy is almost 100% effective. Whooping cough, also called pertussis. Whooping cough is an airborne disease caused by bacteria that mostly affects children younger than 6 years. Symptoms include fever and a whoop sound that occurs when inhaling after a coughing attack. The best way to prevent exposure is to be vaccinated with the DPT or Tdap. You can also place a mask on the patient and yourself. Methicillin-Resistant Staphylococcus aureus. MRSA. MRSA is a bacterium that causes infections. It is resistant to many antibiotics. In healthcare settings, MRSA is transmitted from patient to patient by the unwashed hands of healthcare providers. Studies have shown that 5% to 15% of healthcare providers carry MRSA. It can be transferred to skin and other areas of the body through a break in the skin. Factors that increase the risk for developing MRSA include antibiotic therapy, prolonged hospital stays, a stay in an intensive care or burn unit, exposure to an infected patient. The incubation period for MRSA appears to be between 5 and 45 days. MRSA results in soft tissue infections. Signs and symptoms: localized skin abscesses and sepsis in older patients. Global health issues: MERS-CoV, Middle East Respiratory Syndrome coronavirus, a virus found in animals in the Middle East. The first human case of MERS-CoV discovered in 2012 in Saudi Arabia. Most human infections found in the Middle East. Cases of MERS-CoV have been found in Europe and the United States. Common patient symptoms include high fever, cough, muscle aches, vomiting, diarrhea, in some cases renal failure, respiratory failure, and death. No cure or vaccines for this virus at present. If you suspect MERS-CoV, place a surgical mask on the patient and notify the receiving facility. Ebola. In 2014, an outbreak of the Ebola virus in West Africa, which spread when infected people traveled to other countries, caused international concern. Incubation period is 6 to 12 days after exposure. Symptoms may not appear for as long as 21 days after infection. Symptoms include watery diarrhea, vomiting, fever, body aches, and bleeding. Fatality rate can be as high as 70% if treatment in an ICU is not initiated promptly. If you suspect Ebola, place a surgical mask on the patient, follow PPE precautions as outlined by local protocols and the CDC, and notify the receiving facility.
Travel medicine. You must be aware of travel-acquired infections when assisting a patient who was recently outside of the United States. Patients can present with a variety of symptoms including fever, cough, vomiting, bloody diarrhea, body aches, and rashes. Patient may experience mild symptoms. Some patients become extremely ill. When you encounter an ill patient with a recent travel history, place a mask on the patient and gather as much information as possible. Important questions to ask include: where did you recently travel? Did you receive any vaccinations before your trip? Were you exposed to any infectious diseases? Is there anyone else in your travel party who is sick? What types of food did you eat? What was your source of drinking water? If you suspect the patient has a communicable disease, follow appropriate PPE precautions and notify the receiving facility. Conclusion. The assessment and treatment of medical patients can be challenging and interesting because of the nature of medical conditions. The condition of a medical patient may not be as apparent as in a trauma patient, and treatment may not be as straightforward. Delays in an attempt to diagnose a condition can be harmful to the patient. Keep calm, use your patient assessment skills, treat the patient's symptoms, report to medical control, and transport the patient safely to the emergency department. Patients sometimes have more than one isolated problem. Be prepared to handle any combination of conditions, including conditions of medical patients who have been involved in trauma. Okay, class, let's go over some review questions. Review question number 1. A seizure patient is having what kind of medical emergency? A. Respiratory. B. Cardiovascular. C. Neurologic. D. Immunologic. The correct answer is C. Neurologic emergencies involve the brain and may be caused by a seizure, stroke, or fainting syncope.
Respiratory. A seizure patient isn't necessarily a respiratory emergency. Respiratory emergencies include asthma, emphysema, and chronic bronchitis. Now, when a patient is having a seizure, it is possible for them to stop breathing for a short period of time. Cardiovascular emergencies include heart attack and congestive heart failure. Seizures can cause cardiovascular emergencies because of the lack of breathing. The correct answer is neurologic. A seizure starts in the brain. D. Immunologic, which is an allergic reaction, which are types of immunologic emergencies.
Review question number 2. If an injury distracts an EMT from assessing a more serious underlying illness, the EMT has suffered from A. Tunnel vision, B. Index of suspicion, C. Virulence, D. A trauma emergency. The correct answer is A. As an EMT, you should use the dispatch information to guide your initial response, but do not get locked into a preconceived idea of the patient's condition. Strictly from what the dispatcher tells you. Tunnel vision occurs when you become focused on one aspect of the patient's condition and exclude all others, which may cause you to miss an important injury or illness.
When an EMT allows an injury to distract them from assessing a more serious underlying illness, that is called tunnel vision, not the index of suspicion. The index of suspicion is your awareness and concern for potential serious underlying and unseen injuries or illnesses. Virulence. Virulence is the strength or ability of a pathogen to produce a disease. And a trauma emergency. Trauma emergencies involve injuries resulting from physical forces applied to the body.
Review question 3. If a frequent flyer calls 911 because of a suspected head injury, you should never A. Take the call seriously. Don't waste your time or resources on such a caller. B. Perform a primary assessment. He called for a head injury last week and it wasn't serious. C. Assume you know what the problem is. Every case is different and you don't want to miss a potential serious problem. D. Treat the patient with respect. He is probably lying. The correct answer is C. You are obligated as a medical professional to refrain from labeling patients and displaying personal bias. Never assume that you know what the problem is, even when you are treating patients who frequently call EMS. This attitude could result in missing a serious condition.
Okay, answer A. Take the call seriously. Don't waste your time or resources on such a caller. You never assume you know the patient's problem before you arrive. You should treat every patient equally. Answer B. Perform a primary assessment. He called for a head injury last week and it wasn't serious. You should perform a primary assessment on every patient. It doesn't matter if they're a frequent flyer or not. Answer C is the correct answer. You assume you know what the problem is every case is different, and you don't want to miss a potential serious problem. Answer D, treat the patient with respect. He's probably lying. It's important that you maintain a professional, calm, non-judgmental demeanor at all times.
Review question 4. If your medical patient is not in critical condition, how long should you spend on scene? A, 10 minutes or less. B, 30 minutes. C, 2 hours. D, however long it takes to gather as much information as possible. The correct answer is D. In many cases, the time on scene may be longer for medical patients than for trauma patients. If the patient is not in critical condition, you should gather as much information as possible from the scene so that you can transmit that information to the physician at the emergency department.
Answer A, 10 minutes or less. Critical patients always need rapid transport. The time on the scene should be limited to 10 minutes or less. Answer B, 30 minutes. There's no set time limit for non-critical patients. Answer C, 2 hours. Again, there's no set time limit for non-critical patients. The correct answer is D, however long it takes to gather as much information as possible.
Review question 5. Your patient is having respiratory difficulty and is not responding to your treatment. What is the best method of transport? A, without lights and sirens to the closest hospital. B, with lights and sirens to the closest hospital. C, air transport to a special facility located 30 miles away. D, the patient does not need to be transported. The correct answer is B. Patients with respiratory difficulty generally require high priority transport, especially if they do not respond to your initial treatment. If a life-threatening condition exists, the transportation should include lights and sirens. In this case, it is appropriate to select the closest hospital with an emergency department as your destination.
Answer A, without lights and sirens to the closest hospital. Respiratory difficulty is considered a high priority and requires lights and sirens en route to the hospital. Answer B is the correct answer. Answer C, air transport to special facility located 30 miles away. Respiratory difficulty does not require a special facility. The closest hospital with an ED should suffice. Answer D, the patient does not need to be transported. All high-priority patients should be rapidly transported. Review question 6. When assessing a patient with an infectious disease, what is the first action you should perform? A, scene size up. Take standard precautions. B, obtain a sample history. C, hand the patient off to the paramedic. D, cover your mouth and nose with your hand. The correct answer is A. The assessment of a patient suspected of an infectious disease should be approached much like any other medical patient. First, the scene must be sized up and standard precautions taken. Always show respect for the feelings of the patient and family members and any others on the scene. Answer A is the correct answer. Answer B, obtain a sample history. You must always ensure your own safety before assessing the patient. Answer C, hand the patient off to the paramedic. EMTs are qualified to assess patients with infectious diseases. D, cover your mouth and nose. This action is not necessary. Most diseases are transmitted via the blood or bodily fluids. Remain calm and be respectful.
Review question 7. Your patient believes he has hepatitis and is now exhibiting signs of cirrhosis of the liver. He is most likely to have A, hepatitis A, B, hepatitis B, C, hepatitis C, or D, hepatitis D. The correct answer is C. Cirrhosis of the liver develops in 50% of patients with chronic hepatitis C.
Answer A, hepatitis A. Cirrhosis of the liver is not an indication of hepatitis A. Neither is it an indication of hepatitis B. The correct answer is hepatitis C.
cirrhosis of the liver is not an indication for hepatitis D. Review question 8. Your patient is complaining of fever, headache, stiffness of the neck, and red blotches on his skin. He most likely has A. Tuberculosis, B. Hepatitis B, C. SARS, D. Meningitis. The correct answer is D. Patients with meningitis will have signs and symptoms such as fever, headache, stiff neck, and altered mental status. Patients with meningococcal meningitis often have red blotches on their skin. However, many patients with forms of meningitis that are not contagious also have red blotches. Fever, headache, stiffness of the neck, and red blotches on the skin are not indications of tuberculosis or hepatitis B. Neither are they indications of SARS. They are signs and symptoms of meningitis. Review question 9. What should you do if you are exposed to a patient who is found to have pulmonary tuberculosis? A. Get the BCG vaccine. B. Get a Tuberculosis skin test. C. Undergo serious therapy. D. No precautions need to be taken. The correct answer is B. If you are exposed to the patient who is found to have pulmonary tuberculosis, you will be given a Tuberculosis skin test. This simple skin test determines whether a patient has been infected with M. tuberculosis. Answer A. Get the BCG vaccine. The BCG vaccine is rarely used in the United States, and normally a skin test should be sufficient. The correct answer is B. Get a tuberculin skin test. Serious therapy is not necessary. Getting a skin test should be sufficient. The skin test allows you to see if you have contracted the disease or not. Taking no precautions is not recommended because you could possibly contract tuberculosis. Review question 10. All of the following are factors that increase the risk for developing MRSA except A. Antibiotic therapy, B. Prolonged hospital stays, C. Exposure to an infected patient, D. Close contact with wild birds. The correct answer is D. Factors that increase the risk for developing MRSA include antibiotic therapy, prolonged hospital stays, a stay in intensive care or burn unit, and exposure to an infected patient. Close contact with wild birds is a factor that may increase the risk of acquiring avian flu. Antibiotic therapy, prolonged hospital stays, and exposure to an infected patient all play a role for developing MRSA. Close contact with wild birds does not. Okay, class, this concludes the lecture on Chapter 14, Medical Overview. Thank you for listening. If you have any issues or questions, please contact your instructor, and I'll see you in the next chapter.